So the COVID-19 pandemic has severely impacted the way that medical procedures are delivered. And as a result, there is now an important emphasis on infection prevention in the practice of diagnostic ultrasound. But how safe is the ultrasound examination? All around the world, practitioners are using ultrasound in all streams of medicine. And the transducer can be a vector for the transmission of pathogenic viruses between patients. Contamination risk is increased for those endocavity transducers, such as transvaginal, transrectal, and the transesophageal probes. Organisms transmitted by blood, mucous membranes, genital or rectal secretions are involved with this. And there is resistance in the broader worldwide ultrasound community to implement high standards of infection prevention and control practice. Otherwise, if it's not, we can compromise patient safety. But are ultrasound practitioners aware of the infection risks associated with an ultrasound examination? Do they have the confidence and the knowledge of disinfection methods? And are they trained in basic infection prevention techniques? The World Federation of Ultrasound in Medicine and Biology ran a survey a number of years ago, and we found a huge gap in knowledge of infection prevention and control amongst ultrasound users. There was much discrepancy in current methods of disinfection of ultrasound transducers, and the respondents have requested more education and training and standardized guidelines. For instance, if we look at this image, we asked the practitioners whether they would cover the probe, and most of them said no, 98%. This patient has MRSA, methicillin-resistant Staphylococcus aureus. It can remain viable on surfaces for 2 to 6 months. And if there is viable MRSA on an object or a person, there is the potential for transmission of infection. MRSA may affect lungs, bones, joints, and bloodstream. You need to use a probe cover and then perform high-level disinfectant after the scan. This foot ultrasound, no practitioner said that they would cover the probe. Again, this is MRSA. We need to use a probe cover and HLD post-scan. A vascular ultrasound looking at leg veins, and this also is actually MRSA. First, we need to protect the patient by using sterile gel and using a probe cover. And then to protect the following patient, we need to perform high-level disinfection post-scan. Again, with open wounds, most practitioners would cover the probe. We need to ensure that the transducer has been reprocessed with HLD prior to the scan. Then use a sterile probe cover and using sterile gel. Post-scan, we need to perform high-level disinfection. Is your patient infectious? If you don't know the infectious state of a patient with a rash, then you need to use a probe cover or high-level disinfection after the examination. How many of you have come across this? You walk into an ultrasound room and the previous user has left blood, gel, hair, and even condoms or probe covers lying around. Microbial contaminants can be present on probes that on visual inspection appear to be clean. A couple of recent studies showed that only 51% of blood-contaminated probes were visibly blood-stained. And in another one, 23% of transabdominal probes were contaminated post-scan, but only 42% of those showed no visible soiling. Absence of evidence of contamination is not evidence for absence of risk. Why do clean probes test positive for contaminants? Visual inspection of cleanliness is not a reliable method. The effectiveness of low and high level disinfectant is reduced if those gross contaminants such as gel are not removed prior to reprocessing. It can leave a persistence of active virus or bacteria, and a dirty probe can give the potential for transmission of infection. We should also never assume that a probe cover protects from infection transmission. We tested 5,000 condoms and probe covers and a failure rate of 13%. And this showed the inadequacy of probe covers alone to protect against contamination. Some of those failures were a tiny pinprick in the probe cover, which can allow contaminants to pass through. A dirty probe has the potential for infection transmission. In one study, over 60% of probes in a hospital emergency department were left covered with blood or body fluids after use. Some of the organisms identified on transabdominal probes include a group of the Staphylococcus, which can cause neonatal sepsis, skin infections, infective endocarditis, bone and joint infection, or bacteremia and peritonitis with the Micrococcus species. 31% of transabdominal transducers that we tested were contaminated post-scan. The transvaginal transducer can be contaminated with genital secretions such as cytomegalovirus, hepatitis B, the herpes simplex virus, HPV, HIV, gonorrhea, etc. And this can lead to pelvic inflammatory disease, endometritis, and maybe infertility. And these can remain infectious for days, especially if kept moist in blood or serum. Transducer cords are also a vector for infection, and these should be cleaned between every patient. Some of the contaminants found have been associated with acute gastroenteritis, and endocarditis, and urinary tract infections, and can be a major cause for late onset bacteremia in the neonatal intensive care unit. So remember, we need to clean the entire probe and the cord. Keyboards also need cleaning. Some of the organisms we've identified on the cord, again, Staphylococcus species and Micrococcus, and also fecal material. And some strains of these are associated with neonatal meningitis. Operators can transmit contaminants between patients and keyboards. And it's very important to clean these again between every patient and also washing hands. So why do we need infection control protocols in ultrasound clinics? The literature shows patient deaths from hepatitis B due to a contaminated transesophageal probe, transvaginal probes contaminated with HPV post-probe cover removal and low-level disinfectant. The National Health in Scotland gave a greater hazard for bacterial and viral infections for patients who had undergone transesophageal, transvaginal and transrectal scans. And then recently, patient deaths from septic shock after outbreaks caused from contaminated, supposedly sterile gel. So infections associated with ultrasound, it can be associated with bacterial inoculum from a transducer, and it's much more detectable than the less apparent viral and blood-borne transmissions, such as HBV, HCV, and HIV that may be occurring. It is recognised that the delay in diagnosis of blood-borne infections may preclude an association with a medical ultrasound procedure that may have taken place weeks or months prior. So what can we do about infection prevention and control? First of all, only use a clean probe. All ultrasound examinations should be performed with an appropriately disinfected transducer. If an intracavity or operative scan is to be performed, then ensure that the probe has undergone HLD prior to use. When we look at the definitions, cleaning is the removal of that gross contamination, such as gel, hair, or blood. The disinfection then uses an appropriate germicidal product, and sterilisation is what destroys the viral capsids and bacterial spores. When we're actually reprocessing ultrasound transducers with the Spalding medical classification, the non-critical is for low-level disinfection, and that's probes that have been used on clean, intact skin. The semi-critical requires high-level disinfection, and that's probes used for intracavity scans, such as transvaginal, transrectal, and transesophageal, or probes in contact with body fluids, or those used on infected skin or open wounds without a probe cover. The critical also undergoes high-level disinfectant, and that's used for intraoperative procedures. With cleaning products, we must follow the manufacturer's instructions for use. Otherwise, breaches can occur, which can lead to infection and cross-contamination. Low-level disinfection may not be sufficient for probes used in high-risk settings, even if a probe cover is used. And that includes neonatal intensive care or cardiac intensive care. The types of high-level disinfection can include automated systems, wipes, and chemical soaking. So when we're reprocessing those probes, efficient disinfection will significantly reduce the risk of cross-contamination for the ultrasound patient. An analysis of the relevant international guidelines show a common sequence for best practice. Number one is to remove that gross contamination, such as the gel, from the transducer. And we do this by using paper or cloth or even water with a non-foaming detergent. We need to ensure that all grooves and crevices are cleaned, because transducers do not need to be visibly soiled to be contaminated with those bacterial spores or viral capsids. Step 2, low-level disinfection on every probe. And we perform this by using a germicidal product to remove the bacterial and viral contamination. If we're using a wipe, then friction is needed to help the decontamination process. It is no good just giving a simple pull up and wipe over the top. You actually have to rub the transducer to activate the ingredients in the wipe. Quaternary ammonia compounds and phenolics are not effective against non-enveloped viruses, fungi, or bacterial spores. And alcohol wipes are not germicidal and may negate the probe warranty. Step 3, where required, is high-level disinfection. and that's all probes that have come in contact with body fluid, mucous membranes, or intraoperative procedures. They should undergo steps 1 and 2 and then cleaned with high-level disinfection. High-level disinfection includes approved wipe systems, chemical soaking, or automated systems using chemical or light. Here's an example of a flow chart for reprocessing ultrasound probes. You can see that it's an examination performed using a clean transducer, and it mentions whether it's an external probe on intact skin, it's non-critical, or if there's infected skin, are you using a probe cover or not? Or if it's intracavity or intraoperative, it must undergo the high level. Here's one for after ultrasound guided biopsies or procedures, such as injections. And again, if there's no risk of body fluid, or if a probe cover is being used, it can undergo low level. Or if there's damage to the probe cover and the probe could have come in contact with blood or body fluids, then it must undergo high-level disinfection. We need to say or ask ourselves, the ultrasound users, some are unaware of the dangers of poor infection control practices and hazards potentially exposed to patients. Government and organisations are critical for producing clinical guidelines with recommendations for improved patient safety. And the trade play a pivotal role in training the users how to operate the disinfection systems. In other words, education. Relevant infection control guidelines must look at relevant literature, the local or national regulations. There should be collaboration between ultrasound and infection control experts. There needs to be implementing of staff training to ensure compliance, and should include all alternatives for low and high level disinfection, because we should consider cost of compliance, and we shouldn't endorse or promote any specific commercial product. So in conclusion, are you putting your patients at risk? Failure to comply with established guidelines for the reprocessing of ultrasound transducers can put patient safety at risk. So you need to protect yourself from litigation and an infection by following the guidelines. Would you like an unclean probe used on yourself? Thank you.